Hello guys, welcome to our channel. Today we are going to discuss about the pharmacology part 1. In this part 1, I have included the cardiovascular drugs, diuretics, anti-lipidemic drugs, endocrine drugs and the monoclonal antibodies. So each and every topic is very important. At least we can expect from this topic itself 5 to 6 MCQs we can expect. Okay. So before we late, let's start the discussion. And in those who are new to this channel, please do subscribe and share with your friends. So let's start the discussion. First, we are going to discuss about the cardiovascular system. In the cardiovascular system, basically the most of the drugs will be included for the hypertension only. So let's see one by one. So first, we all know that sympathetic system and the parasympathetic system. In the autonomic system, we are going to activate the alpha agonist. Why? Alpha agonist is going to helpful for us. We are going to provide the hypertension below by doing the vasodilation, right? We also have the alpha antagonist, means alpha action will be the vasoconstriction, so that indirectly we are going to decrease the antagonism. Alpha 2, in the briefly in the alpha 2, it is going to do the smooth vascular system going to be relaxed. So these are the major actions for the alpha 2 and the alpha antagonist. Let's see one by one. Alpha 2 antagonists for alpha 2 agonists are alpha methyl dopa. This is used for the basically for the pregnancy induced hypertension, and but it is associated most commonly with the hemolysis, and direct to Coombs test will be positive. Next, clonidine, which we are going to use for the ADHD, attention deficient disorder, hypertension urgency as an oral drug, and Tourette syndrome, so that we can decrease the calcium channels, alpha 2 agonist, and we can decrease the ongoing the disorders of the movement disorders for the Tourette syndrome. Next, alpha antagonist, the drug is commonly used is a prazosin, used for the benign prostatic hyperplasia with those who are suffering from the hypertension, and also this is given for the scorpion bite, right? For the patients those who are suffering from the scorpion bite also we can give the prazosin. And next, phenoxybenzamine, that is used for the pheochromocytoma patients. Next, coming to the beta blockers, they are the first generation beta blockers and the second generation beta blockers. First generation beta blockers are non-cardioselective. What are those drugs? Starts from N to Z, okay, non-cardioselective. And A to M, this is mostly cardio-selective drugs. So let's see examples. What is this first generation drugs? Propranolol. We all know that we are going to use commonly for the migraine, anxiety and thyroid associated conditions because it is a beta blocker. Okay, so beta blocker, if we block the beta, that will cause the vasodilatation, and also it is going to do the anxiety related issues and thyroid mechanism in the iodine synthesis also it is going to helpful. Timolol is an myotic drug, it is going to be the ophthalmologic drug used for the glaucoma patients. Pendolol and the nadolol, this is also commonly used for the anxiety related disorders. Next, the second generation, as I said, these are the mostly cardiovascular. So in the cardiovascular, metoprolol we use for the MI patients. Carvedilol, this is used for the commonly anti-arrhythmia. Acebutolol or metoprolol and nebivolol, all these are can be also used for the hypertension patient. Next, third generation drugs, this is only purely for the vasodilation. Bisoprolol, betoxolol on the celiprolol. Okay, remember this way, BBC, right? Bisoprolol, betoxolol on the celiprolol. Next, alpha plus beta action seen in the labetalol and the carvedilol, where we are going to use the labetalol in those who are suffering from the PIH, okay, pregnancy induced hypertension emergency, we are going to use the labetalol. And next, CCB, which will be having the beta blocker and also calcium channel blocker action, that is the carvedilol. And nitrogen oxide action will be seen in the starts with the NN, okay, nebivolol and the niprodilol. And antioxidant properties seen in the nebivolol. And antidote, if there is an increased intake of the beta blockers, IV glucagonol can be given for this patient. Next, longest action nadolol and shortest landilol or the esmolol. Esmolol is also seen in the anti-arrhythmics classification. Best cardiovascular selective nebivolol on the most extra cardiac outside the cardiac tissue, propranolol, and potassium blocker, sotalol, and partial agonist are penbutalol or the pindolol or the acebutol, and paralyze the cell membrane, propranolol and the metoprolol. What are the uses we commonly use for the beta blockers? Hypertension, migraine, arrhythmia, glaucoma, anxiety, thyroid conditions, essential tremors, and chronic cardiovascular heart failure and aortic dissection. Contraindications, we are blocking the beta channels. If we block the beta channels, there is a high chance of the vasoconstriction. So asthma, COPD should not be given. AV blocks because the AV conduction will be decreased in this patient. Acute cardiovascular system because it is a discompensated heart failure, we should not give. Prinzmetal angina, already prinzmetal angina is a vasoconstrictor, right? And if we block more vasoconstriction, this will be trigger. And diabetes mellitus because again beta is blocking. If the beta is blocked, insulin release will be decreased. Diabetes mellitus we should not be given, and depression patients also we should not given. What are the side effects? It will decrease the heart rate and the BP. AV block, AV conduction block, bronchospasm, nightmares, insulin sensitivity will be decreased, and masking hypoglycemia, increased triglycerides, LDL and decreased HDL, and also long-term extracardiac drugs will cause the impotence. Next, coming to the renin drugs. Okay, basically what the renin is activated when there is a decreased BP, when there is a decreased renal perfusion. What happens? Renin will be activated. What it is going to do? It is going to convert the angiotensinogen to angiotensin 1, and angiotensin 1 with the help of the ACE from the lungs, it is going to convert it into the angiotensin 2. What does this angiotensin will do? It will increase the thrust so that the vein fluid overload and BP will increase. It will increase the total peripheral resistance, vasoconstriction, again BP will increase, and it will increase the sodium and the hydrogen ions increase, so that again what happens? BP will be increased. All else it is directly going to activate the aldosterone, and aldosterone will be increasing the blood pressure and the cardiac output. So this is how the renin system will be working. But we cannot keep on increasing the BP, so sometimes it will be going to the pathological. So for that what we are going to do? We are going to block the renin. How? With the drug. Directly, if you want to block the renin from the production itself, the drugs are the alcikirin and the enalkirin. Or if you want to block the ACE inhibitor from the lungs, we are going to use the ACE inhibitors. Or you want to block the ERBs, angiotensin receptor blocker, and you have these drugs. So let's see what are those drugs and classification. So the first classification is the ACE inhibitors. What are these ACE inhibitors, guys? They are the prodrugs. All are going to be the prodrugs except lisinopril and the captopril. Next, shortest acting is the captopril. Longest acting is the perindopril. And all these drugs is commonly used for the first line of the treatment for the hypertension patients, those who are less than 55 years old. And what are the common side effects? Dry cough, angioedema, and also hyperkalemia will be seen in this patient. Absolutely contraindications, those who are suffering from the pregnancy, end stage renal disease, and bilateral renal artery stenosis, we should not be giving this drugs. Next, ERBs, angiotensin receptor blockade, so that the aldosterone is not produced and further BP will be not increased. And same here, all are the prodrugs except candesartan and the olmesartan. And what is the main mechanism of action for the ERBs angiotensin receptor blockade? But if we start with this angiotensin receptor blocker with PPAR gamma blocker, so what happens? It will be going to decrease the most of the PPAR gamma actions, such as platelet aggregation and also insulin sensitivity, which will be increased in this patient. So what are the examples with the PPAR gamma receptor? Telmisartan and the losartan. Losartan has a special properties. It will decrease the platelet aggregation, it will decrease the uric acid, and also decrease the insulin resistance. Along with this, also hypertension decrease. This is a very common drug used in the other Western countries as a losartan because of the other benefits. And commonly in India, we are going to use the telmisartan, those who are suffering from the diabetes mellitus and the hypertension together. Short acting, aprosartan, long acting, telmisartan. Next, side effects are hyperkalemia, same as that, and the creatinine and pregnancy contraindication. Alright, next calcium channel blockers. And what are the examples, guys? Calcium channel blockers. Remember, nifedipine, it is a tocolytic. Nimodipine, it is going to be the cerebroselective. And nicardipine is going to use for the hypertension emergency. Side effects are commonly headache, gingival hyperplasia, ankle edema, and also constipation. Constipation is commonly seen with the verapamil. Ankle edema is seen in the amlodipine, and it is going to use for the AV block conduction, such as diltiazem, common drug can be used. And if we are given with the beta blockers, can cause the systolic and the reflexive tachycardia is also seen in this patient. And calcium channel blockers, other use is the Prince metal angina and those who are suffering from the hypertension more than 55 years old. Okay, next, moving on to the potassium channel openers. What are the potassium channel openers? Minoxidil, and usually minoxidil you commonly side effect is hirsutism. So that we are not going to use for the BP because it can do the potential lower BP, hypertension will be seen. But anyway, hirsutism is seen as a side effect, so we started using for the alopecia. And diazoxide is commonly decrease the BP, it will increase the insulin. So commonly we are converted this for the insulinoma patients. And hydralazine, it is going to cause the SLE, right? So the drug which can cause the drug lupus. And commonly again it is used for the PIH when the labetalol is not working, alpha methyl-dopa is not working, then you can go for the hydralazine drug. And also we can use for the cardiovascular system of the heart failure. Next, hypertension protocol. How we are going to use the hypertension protocol? If the patient is less than 55 years old, ACE inhibitor and the herb drugs can be given. If the patient is more than 55 years old, calcium channel blockers, amlodipine. And if it's a resistant hypertension, spironolactone. If it is a hypertension urgency, clonidine. If there is a hypertension emergency, nicardipine. If there is a hypertension emergency in the pregnancy, labetalol. Hypertension with the osteoporosis, and we are going to use the clothalidone. Thiazide drugs we are going to use. Renal stones plus the hypertension, clonidone. Again thiazides we are going to use. Hypertension plus the diabetes mellitus patient plus the CKD, or from the nephrotic syndrome or the scleroderma, we can use the ACE inhibitors or the herb drugs. Hypertension plus gout, losartan. Hypertension plus the Raynaud syndrome or the cyclosporine, calcium channel blockers. Hypertension plus the benign prostatic hyperplasia, prazosin. Hypertension with the migraine, angina, post-MI, thyroid, anxiety, essential tremors, we can use the beta blockers as a drug of the choice. Next, coming to the heart failure. It can be acute compensated, acute decompensated, or the chronic decompensated. What are the most common causes? Acute is due to MI, okay, mainly due to the MI, and chronic is mostly due to the hypertension patients. So how we are going to start the treatment for the heart failure patients, those who are suffering from the acute and the chronic? So let's see, in the acute patients, we are going to start with the IV furosemide and the IV dobutamine. These are the first line treatment, guys. Direct we are going to use the IV drugs. Why? Because this furosemide can cause the pulmonary edema, so that we have to decrease the pulmonary edema. And IV dobutamine, we have to increase the ionotropy effect. So if they are not working, so then we can go for the neriticide and the nitroglycerin. And if the IV dobutamine is not working, then we can go for the milrinone, which is a increase the phosphodiesterase enzyme 3. It is going to block that, and further it will increase the CAMP activity in the heart. And in the chronic patient, you can start again for the furosemide, decrease the pulmonary edema, and ACE inhibitor, it will decrease the blood pressure and the fluid overload. And sacubitril, if it is not working, we can add on, this is the add-on, we can add on with the sacubitril, and we can add on with the beta blockers such as bisoprolol, metoprolol, carvedilol, and the nebivolol. And common question that can be asked, which is going to decrease the mortality. In the mortality decrease, what are the drugs we have, those can decrease the mortality, guys? Sacubitril, SGLT2 drugs, and ivabradine, hydralazine, spironolactone, ACE and ERB inhibitors, and beta blockers, and vericiguat, which will be increase the CGMP activity by the increasing the NO. So all these drugs are the best drugs can be given for the patients those who are suffering from the heart failure. Anti-anginal drugs in the acute stage, we are going to use the nitroglycerin. The main mechanism action is the increased CGMP activity. Variant angina, calcium channel blockers, such as just now we discussed Prince metal angina. Long-term angina, beta blockers, calcium channel blockers, and the long-standing nitrates can be given for this patient. What is the mechanism of the ivabradine? It is going to block the funny channels such as sodium funny channels. It is going to block, and it will block the SA node. What happens if you block the SA node? It is going to decrease the heart rate. Right? Side effects are AV block, atrial fibrillation can be triggered, and visual halos. Next, ranolazine is going to block the sodium channel blockers late influx, right? This is going to be our cardiovascular system, and here we are going to have the late influx. So we are going to block the ranolazine in this block. And what happens? Side effects will be the risk of the atrial fibrillation compared to the ivabradine is going to be decreased, but QT prolongation is seen in this patient, and insulin resistance is also going to decrease. Next, dipyridamole, and it is going to block the adenosine and phosphodiesterase. What it is going to do, the benefits of this vasodilation can be seen, and platelet aggregation can be decreased with this patient. And what are the side effects? Coronary steal phenomena. Coronary steal phenomena because you are blocking the adenosine and the phosphodiesterase enzyme. So it is going to show the coronary steal phenomena. Next, nicornidol, and it is a calcium channel opener. Phosphodyl Rho kinase inhibitors, and trimetazidine, it is an anti-metabolite. Partially it is going to block the fatty acid oxidase, and it will decrease the triglyceride metabolism, increase the glycolysis, and decrease the oxygen demand with the heart. Next, coming to the most important, anti-arrhythmics. So this is then ventricular action potential. So this is the phase 4, phase 0, phase 1, phase 2, and the phase 3. In the phase 4, slow influx of the sodium, phase 0, late influx of the sodium, and phase 1, potassium is going out, and phase 2 is a plateau phase. Why it is a plateau? Because simultaneously calcium influx and the potassium efflux. And in the phase 3, complete potassium is going to come outside. So this is the depolarization. This is again coming back to repolarization. This is the plateau phase of the ventricles. So they are importantly 5 classes. If we have to discuss about the anti-arrhythmic drugs, what are those? Class 1 is an completely sodium channel blockers, and class 2 beta blockers, class 3 potassium channel blockers, class 4 is a calcium channel blockers, and class 5 is a miscellaneous. We are going to discuss in a while. So let's see one by one. So class 1 is divided into the 3 types: 1A, 1B, and 1C. So 1A is going to act on the sodium channel blockers and also block the potassium channel blocker. 1B, only sodium channel blocker and potassium channel is open. And 1C, sodium channel is closed and potassium channel is closed, but very less than 1 second. It is a very minimal effect, but the strong effect that you are going to see is in the 1A only, sodium channel and the potassium channel blocker. What happens when we block the potassium channel? So here you can see this is the normal and this is the abnormal in the red color. So what happening? The QT, so the QT prolongation is seen. So that is why the potassium channel blocking can trigger the increased QT prolongation. So that is the one of the important thing that you have to remember, with the sodium channel blocker and the potassium channel blocker together. What are the examples? Quinidine, prokinamide, and dispyramide. So quinidine is going to cause a synchronism, and prokinamide also causes the QT prolongation. Dispyramide, it is going to cause the anticholinergic and congestive heart failure, glaucoma, or the benign prostatic hyperplasia. So we are going to not give those who are suffering from these conditions. So these are the important side effects that you have to remember. All are going to have the QT prolongation with the 1A classification. Next, 1B, it is going to open the potassium channel. So there is no chance of the QT prolongation. Here you can see The QT prolongation is not seen. It is within the normal only. So only it is decreased action potential. Here only you can see action potential is delayed. What are the uses, guys? MI associated ventricular fibrillation, digoxin, arrhythmia can be seen. So what are the common examples? Lidocaine, phenytoin, mexiletine, and the tokinite. Next, 1C drugs. What are the 1C drugs? Sodium channel is strongly closed and potassium channel is very less than minimal effect. So again, action potential is only going to be decreased here and QT prolongation is normal. What are the drugs? Flecainide is used for the commonly WPV syndrome chronic conditions, echinide and propafenate, most erythromogenic drug, and morphine. Next, class 2 beta blockers. It is going to decrease the AV conduction and atrial fibrillation, flutter, ventricular tachycardia, supraventricular tachycardia, and long QT syndrome. We can use the beta blockers. You all know cardiovascular selective drugs. What are those guys? Metoprolol, bisoprolol, bendelol. All these drugs can be used for the beta blockers anti-arrhythmics. Class 3 potassium channel blockers. Here again potassium channels can block the QT prolongation, right? So ibutyloid, maximum with the ibutyloid and minimum with the amiodarone. Sotalol and vernaculant and dofetilide and beryllium. These are the common drugs that we are going to use in the patients of the potassium channel blockers. Amiodarone. What is the amiodarone? It is the most anti-arrhythmic drug. Why? Its mechanism of action is it is going to block the alpha, potassium blocker, sodium channel blocker, calcium channel blocker, beta blocker, lipophilic drug, and P-glycoprotein also going to be blocked. All this is going to decrease the arrhythmia. So that's why this is the most anti-arrhythmic drug. What is the half-life? 53 days. Okay, so it is going to cause the hypotension, pulmonary fibrosis, blue skin, brown skin, ceruloderma, and corneal oral deposits, liver and hypothyroid dysfunction, and neuropathy and the myocarditis. So these are the common side effects with the patient suffering from the this drug indication or the ingestion. Next, class 4 calcium channel blockers, verapamil and the diltiazem. It is also going to decrease the AV conduction, commonly used for the blocking of the AV node. Next, class 5 adenosine drug. So miscellaneous drugs that we are discussing. A1 and adenosine 1 receptor and adenosine 1 gamma is going to be blocked with this. And A1 is used for the cardio, A2 is used for the lungs. Remember this way, A1 1 heart, A2 2 lungs. Contraindications, asthma patients, bronchoconstriction will be seen. Ivabradine, another classified miscellaneous, ivabradine, MGS44, atropine and the digoxin. Ivabradine is going to block the funny current channels. Magnesium sulfite, it is going to block the calcium channels. Atropine is going to increase the AV node and digoxin is going to block the AV node. Right? These are the important mechanism of actions. And coming to the digoxin, it is going to block the potassium ATPase pump. Okay, sodium potassium ATPase pump. What happens? So diarrhea will be seen, nausea, vomiting, decreased calcium, increased calcium, decreased potassium and decreased magnesium will be seen because we are blocking the sodium potassium ATPase exchanger. Next, risk of MI, renal failure, WPV syndrome triggering and the increased of the hypertrophic obstructive cardiomyopathy complications will be seen. Gynecomastia, xanthospia, green halos, and ventricular bigamy is commonly seen with this patient. What is the treatment? Decreased potassium, give the potassium for this patient. And if it is serious, then we have to give the digoxin along with the lidocaine. Digoxin fab fragments, that is the digoxin, it is an antidote of the digoxin. Next, moving on to the another topic, diuretics. In the diuretics, we all know that this is a classification: proximal convoluted tubule, loop of Henle, and distal convoluted and collecting duct. Here we are going to have the what drugs, guys? Here you can see carbonic anhydrase. In the loop of Henle, osmotics, thick ascending limb, there is a loop diuretics, and distal convoluted tubule thiazides and collecting tubule potassium sparing agents. Next, cardiac anhydrase inhibitors. This is acting in the PCT. What are the drugs? Acetazolamide, brizonamide and the dorzolamide. So what are the uses? mountain sickness, acute closure glaucoma, increased CSF fluid or the increased cranial tension, pseudocerebral tumor, cystine stones are the catamenial epilepsy patients also we can use. So these are the common uses. What are the side effects? Metabolic acidosis will be seen, increased RTA2 risk and decreased potassium, hyperammonia contraindicated in the liver diseases, sulfa allergy, renal stone accumulation and the somnolences. So these are the side effects of the carbonic anhydrates. Let's move on to the loop diuretics where it is acting thick ascendingly. So that it is going to block the sodium, potassium and the chloride channels. What are the drugs? Furosemide, trosimide and bumatanide. And uses are hypertension patients, pulmonary edema patients, and those who are suffering from the end stage renal disease with the GFR less than 40, increased calcium we can give, and iodide poisoning also we can give this drug. And what are the side effects? It is the most ototoxic. So how can you remember? E for ear, E for the ethacranic acid. So very ototoxic, it can damage the cochlea. And loop loses everything. How? Because it is going to block the sodium, potassium, chloride. Along with that, it is going to block the calcium, magnesium, and all these are going to be loose in the urine. So increase the prostaglandin activity, increase the uric acid activity and beta 3 activity. Further, it is can damage the hyperglycemia. So uric acid patients we should not give, hyperglycemia patient we should not give the diuretics, and metabolic alkalosis is the one of the side effect. Thiazide drugs we have, it is going to act in the DCT. What is the mechanism of action? Sodium and the chloride channels will be blocked, and hydrochlorothiazide, chlorothalidone and the indapamide and metazoline can be used. And only drug that is safe is the metolazone, and indapamide it is excreted by the liver. So those who are suffering from the end stage renal disease we can give these two drugs. Next, what are the common uses guys? Hypertension with the osteoporosis, renal failure less than 40 GFR and hypertension, nephrogenic DI and diabetes insipidus patient, edema, hypercalciuric stones we can give. What are the side effects? Metabolic alkalosis, sodium channel is decreased and potassium is out, magnesium is out. But only that is preserved comparing to the loop diuretics, that is the calcium. So calcium will be reserved. So uric acid, glucose, thiamine reduction, dyslipidemia, same as the loop diuretics we are going to see. And the diseases that you have to remember. And potassium sparing drugs. Those who are new to this these channel, please do subscribe. Divided as a subtypes: mineralocorticoid receptor blocker and sodium channel, epithelial sodium channel blockers. So what are those drugs? So the drugs that is mineralocorticoid drugs, spironolactone and the eplerenone, and ENaC channel blockers, triamitron and the amyloid. And what are the uses? Ascites, edema, resistant hypertension, Conn syndrome, lithium associated diabetes insipidus, chronic heart failure, PCOD, cystic fibrosis, Liddle syndrome we are going to use. Side effects are metabolic acidosis, increased potassium. We are sparing the potassium. Obviously, potassium will be increased. Gynecomastia, anti-arrhythmias, folic acid deficiency, impotence and the menses problem will be seen in this patient. Next, last one, osmotics. It is a loop of Henle drug, mannitol, and it is going to block the water intake. So cerebral edema, closure glaucoma, increased intracranial tension, dialysis equilibrium and impending renal failure, we can use this drug. What are the side effects? Potassium will be decreased or increased, sodium will be increased or decreased, depends on the cerebral and the renal uses. Contraindications: pulmonary edema, heart failure, renal failure, liver disease. We should not give any of these osmotic drugs. So these are the diuretics classification. Next, moving on to the lipid lowering agents. What are these lipid lowering agents? Let's see. The drugs are the statins. Commonly using the statins because it is going to block the cholesterol synthesis, HMG-CoA reductase. The best benefits of the cholesterol synthesis when we are blocking: LDL will be decreased, triglycerides will be decreased, VLDL will be decreased. So we need the increase of the HDL and lipoprotein like A. So this is also beneficial for those who are suffering from the hypercholesterolemia. So pitavastatin, most potent. Rosuvastatin is going to be the long acting. Pravastatin is a hydrophilic drug. It is not metabolized by the CYP450. So next, moving on to the statins. Statins have the multiple activity such as anti-inflammatory, antioxidant, anticoagulant, anti-aggregant, plaque stabilization, increased nitric oxide. So along with the statins use, so these many benefits. So that's why we commonly going to start with the statin in the patients early as possible in the cardiovascular or the cerebrovascular diseases. Uses type 2 diabetes mellitus, type 2 cholesterol disease, stroke or the MI patient prophylaxis. The common side effects is myopathy, hepatotoxic, insulin resistance and the contraindications in the children and pregnancy. Another classification, fibrates, it is going to increase the PPAR gamma activity. So decrease the triglycerides, decrease the VLDL and the chylomicrons. So fenofibrate, gemfibrozil, these are the drugs. Side effects are gallstones and the myopathy. Next, bile acid binding salts, and all drugs are with a chole. Okay, like chole. So bile, chole, like the drugs will be seen. Enterohepatic circulation will be blocked. LDL is decreased. So again, common side effects will be malabsorption, the GI upset, and decreased ADAK channel will be blocked, and increased triglycerides, hypercholoremic acidosis will be seen. It can be given for the patients those who are suffering from the if the lipid disorders in the pregnancy or the children, we can give this bile acid drugs. And PCSK blocker. So this is the common drug evolocumab, and maximum LDL and the lipoprotein A activity will be decreased in this patient. And the PCSK9 synthesis blocker, that is the inclisiran. Okay, inclisiran drug, and this is going to start with a small interfering RNA activity and block the mRNA activity of this synthesis. Next, bempedoic acid. So how can you remember? ATP citrate lysis. So ABC. So ATP bempedoic acid citrate lyase. Remember this way, it is going to decrease the cholesterol and the LDL. And lometapide, it is going to block the MTP. The name itself tells lometapide, MTP blocker. MTP means microsomal triglyceride transport protein. Next, evinacumab, it is going to block the angiopoietin protein 3, decrease the LDL and the triglycerides. Icosapent, it will decrease the triglyceride rich and VLDL via liver and platelet aggregation. Ezetimibe, it is going to block the cholesterol absorption and decrease the NPC1L1 receptor. And niacin, hormone sensitive lipase blocker, and decrease the lipoprotein A and increase the LDL. So commonly it is going to cause the hepatotoxic, flushing and insulin resistance. Other drugs which are decreasing the LDL, losartan, beta blockers, metformin and thiazolidides. Increase the LDL activity, beta blockers, thiazides, loops, steroids, OCPs, cyclosporin, retinoids, ritonavir and clozapine. All these drugs will increase the indirectly LDL activities. Next, moving on to the endocrine drugs. Oral hypoglycemic drug, very important. We are going to have the quick revision and important revision. Bigunides. The drug of the choice is metformin, commonly used for the diabetes mellitus. Okay, so this is used for the diabetes mellitus type 2. Hepatic glucose is actually decreased by the metformin production, and insulin sensitivity decreased LDL activity. And lactic acidosis, B12 deficiency, GI upset, end stage renal disease, we should not be given. These are the common side effects. And sulfonylureas, the drugs are commonly glyburide, limiprid, and insulin secretion will be increased. Beta cell activation, potassium channel blockers is the mechanism of action. Weight gain, hypoglycemia, and contraindicated in the heart diseases. And meglitinides, same as the sulfonylureas but short acting, and side effects also associated same. DPP4 blockers, all drugs are ending with the gliptons. Okay, glipton, sitaglipton, linaglipton, these are the drugs. And DPP4 enzyme will be blocked, so further incretin activity will be increased. So if the incretin is increased, it is going to increase the insulin and decrease the glucagon. Pancreatitis, nasopharyngitis, weight loss, linagliptin is renal safe and these are the side effects. Okay, and GLP-1 receptor agonist, that means we are increasing the activity. Again, increasing the incretin activity, increase the insulin and decrease the glucagon. Glutide, semaglutide, these are the drugs. Glutide, which will be ending with the glutides, those are the drugs. Nausea, vomiting, pancreatitis and weight loss is seen in this patient. SGLT2 inhibitors, gliflozins, canagliflozins, glycosuria is the common action. In the kidneys, we are going to see the increased urine output. And UTI, genital infections, DKI, dehydration, weight loss, and those who are suffering from the heart failure, these are the best drugs. And amylin analogs, what are these amylin analogs? Pra-amylitide. Here itself you can see amylin. Okay, pra-amylitide decrease the glucagon and decrease the gastric emptying. So further, it is best used for the subcutaneous type 1 and type 2. Alpha glucosidase inhibitors, acaribose, vaglibose. Intestinal absorption is decreased of the carbohydrates. So what happens? GI upset, diarrhea, flatulence, and inflammatory bowel disease, liver conditions. We should not give this directly acting on the intestines. Last drug, glitazones. Okay, thiazolidinidones, pioglitazone, PPR gamma activity increased. So GLUT4 via GLUT4 insulin sensitivity is increased. Weight gain and contraindicated in the heart failure patients, decrease the LDL, renal safe, but fracture and the bladder cancer risk will be seen in this condition. Okay, next coming to the thyroid. So commonly there are the two types of the drugs, guys. One is going to use for the hyperthyroidism, other one is for the hypothyroidism. Okay, these are only the main classification. So prothiouracil and carbimazole, methimazole, this is used to block the thyroid peroxidase. So in the first trimester PTU, second trimester carbimazole. What are the side effects? It is a highly hepatotoxic, agranulocytosis and also cutis aplasia if we are given in the first trimester. Glucose decrease the vascularity, decrease the size. So it is going to block the thiol endopidase. What we are going to use, if it is decrease the vascularity, decrease the size, best for the pre-operative period because we can easily visualize and easily ligate without bleeding. Radioactive iodine, this is used for the destroying the follicular cells via beta rays and cancer due to radiation, pregnancy contraindication. Levothyroxine increase the decrease the TSH, right? So those who are levothyroxine is going to increase the thyroid synthesis, and those who are suffering from this condition, thyroid hypothyroidism we can give, but osteoporosis and the atrial fibrillation will be seen. So next we are going to discuss about the steroids, guys. Hydrocortisone commonly used for the adrenal insufficiency, acute shock. Prednisone is used for the autoimmune conditions like the rheumatoid arthritis and also lupus patient. Prednisolone is used for the asthma and the inflammatory conditions. Methylprednisolone is used for the severe asthma and the spinal cord injury. Dexamethasone, betamethasone commonly used for the fetal lung maturity, preterm labors, and Dexa is used for the cerebral edema, antiemetics such as chemotherapy. Triamcinolone used for the intra-articular conditions such as arthritis and also used for the keloid injection. Budesonide is used for the bronchial asthma, inflammatory bowel disease. Fluticasone used for the asthma and the allergic rhinitis. Beclomethasone used for the asthma maintenance therapy. Clobetasol is used for the skin conditions such as psoriasis. Mometasone is used for the dermatitis and the allergic rhinitis. And this is a common ionicity question that is asked: dexamethasone doses and the betamethasone doses for the preterm labor. So dexa A, B, C, D. So this is a 4. So we are going to give the 4 doses of 6 mg every 12 hours. Okay, total 24 mg. D for 4. So 4 doses will be given. Beta A, B, only 2 doses. Lung maturity every 24 hours. 12 mg is given. Total 24 mg. Okay, this is the doses. So rituximab CD20 blocker used for the non-Hodgkin lymphoma and the rheumatoid arthritis. Trastuzumab is used for the HER2 blocker receptor and the HER2 positive breast cancer. Bevacizumab is targets the VEGF blocker, colorectal and the solid tumors we can use. Cetuximab is used for the blocking of the EGFR, colorectal cancer. Panitumumab is again block the EGFR, colorectal cancer. and infliximab used for the TNF alpha blocker for the rheumatoid arthritis and the Crohn's disease, and adalimumab, again TNF alpha blocker, rheumatoid arthritis, and etanercept, TNF receptor blocker, rheumatoid arthritis, tocilizumab, IL-6 receptor blocker for the rheumatoid arthritis, and we can use for the asthma as well. And ustekinumab is going to block the IL-12 and IL-23 and for the psoriasis. Omalizumab, IEG blocker, severe asthma, and eculizumab, C5 complement blocker for the paroxysmal nocturnal hemoglobinuria, and natalizumab is for the alpha-4 integrin multiple sclerosis. Denosumab, rank ligand blocker for the osteoporosis, plavizumab for the RSV-F protein blocker for the RSV prophylaxis in the infants. So these are the important drugs and their conditions and uses, side effects that should be thorough. And please don't forget to subscribe and share with your friends, and stay tuned for the all 19 subjects and also pharmacology part 2 and part 3. So all the best, happy preparation. Please do subscribe and like and share with your friends.